Hello and welcome to today's session. Today's session we are looking at oral hypoglycemics. Oral hypoglycemic class. In the previous class, we looked at the insulin and insulin analogs. Kindly find time and a link will be popping up where you are able to review the two. Remember, in oral hypoglycemics, we have 8 classes of drugs. We have biguanides, and good examples are metformin. We have sulfonylureas. Good examples is the glibenclamide. We have thiolidones, and we have the pioglitazones. We have the DPP4 that we normally we abbreviate them and they mean that it is dipeptide peptidase 4 inhibitors. They include sitagliptin. We have alpha glucosidase inhibitors. These ones they normally work in the intestines. Okay, a good example you have acarbose. Okay, then you have sodium glucose cotransporter 2 inhibitors. This one works in the kidney. Okay, we have canabloflozin. Then you have the meglitinides. These ones they work more or less like the sulfonylureas. Good examples could be nateglanide. And then lastly we have bile acid sequestrants. Okay, so these are medication primarily used to lower cholesterol levels, but is also has a modest glucose lowering effects. So it works by binding to bile acids in the intestines, leading to improved glycemic control. Okay, so it can be classified under oral hypoglycemics, but primarily it's used to lower cholesterol levels. Okay, so guys, let's delve into some of them and see what they're involved. But we have to understand we have those 8 basic classes. Number 1, we have them. We have the biguanides. Okay, remember. Oral hypoglycemics are also known as oral anti-diabetic drugs or oral diabetic medications. They are normally taken orally so that they can be able to help us manage high blood glucose levels in patients of majorly of type 2 diabetes. The mechanism of action will involve increasing insulin sensitivity, increasing insulin production, and reducing glucose production by the liver, gluconeogenesis. So we have already mentioned examples, and the first one is biguanides. These are a class that are used primarily to manage type 2 diabetes. The most commonly prescribed, okay, and well-known one is metformin. Yeah, who doesn't know metformin, guys? Yeah, this is the most common biguanide. It's often considered the first line treatment for type 2 diabetes due to its proven effectiveness, safety profile, and additional health benefits. Okay? Correct. So, biguanides work by improving the body's response to insulin, making the body cells more sensitive to the effects of insulin, and this helps lower blood glucose level and improve glucose utilization by the cells. One of also the main action of metformin is reducing the production of glucose by the liver, gluconeogenesis. So in people with type 2 diabetes, the liver often releases too much glucose into the bloodstream, contributing to high blood sugar levels. So metformin helps to counter this effect. Metformin is also considered weight neutral or may lead to slight weight loss in some individuals. So this is contrast with other diabetes medication that are normally associated with weight gain. So while others are associated with weight gain, this one causes weight loss or weight neutral. Okay, the maximum dose is normally 2000 milligrams per day, guys. Beside its glucose lowering effects, metformin has also shown a positive cardiovascular effects. It may reduce the risk of heart disease and improve lipid profiles in some individuals. Also, when used as monotherapy, metformin is associated with low risk of causing hypoglycemia, especially when you compare it with other diabetic medication. Metformin is also used to manage insulin resistance in women with polycystic ovary syndrome. This condition is related to hormonal imbalance and insulin resistance. So while metformin is generally well tolerated, it may not be suitable for everyone, particularly those with certain medical conditions such as kidney impairment may not benefit from this prescription. The second class after biguanides is the sulfonylureas, and sulfonylureas stimulate the pancreas to release more insulin, helping to lower blood glucose level. So their MOE mechanism of action is that they work by stimulating beta cells in the pancreas to release more insulin. So they bind to specific receptors on the beta cells, which are supposed to produce insulin, then leading to opening of potassium channels, depolarization of the cell membrane, and subsequently releasing insulin. They are indicated to lower blood sugar levels in people with type 2 diabetes when lifestyle changes alone are not enough to control the conditions. Examples include glibenclamide, glipizide, gliclazide, glipiride, okay, the G's. The risk for hypoglycemia is that one of the main side effects of the sulfonylureas is hypoglycemia, which occurs when blood glucose levels drop too low. This happens if the dose is too high or if the person misses a meal or engages in strenuous physical activity. Sulfonylureas are not recommended for use in patients with type 1 diabetes since they require residual insulin secretion for drug to be effective. So I hope you have encountered some situations whereby somebody is just on metformin and not combined with glibenclamide. Okay? Yes, this one needs some residual insulin secretion for the drug to be effective. So they should also be used cautiously in persons with impaired kidney or liver functions. Apart from hypoglycemia, sulfonylureas can also cause weight gain and may lead to a decrease in number of insulin receptors over time. Thus, they reduces the response to the drug, okay? On combination, sulfonylureas can be used in combination with other oral anti-diabetic medications such as metformin or the dipeptide peptidase 4 inhibitors to achieve better glycemic control. So patients taking sulfonylureas should be educated about the risk of hypoglycemia and how to manage it. Pregnancy and breastfeeding, you find that sulfonylureas are not recommended during pregnancy or breastfeeding due to the potential risks to the fetus or the newborn. After looking at the biguanides, sulfonylureas, we go to the meglitinides. So these meglitinides stimulate the pancreas to produce insulin, but they have shorter duration of action compared to sulfonylureas. So they work more or less like the sulfonylureas, the glibenclamide, but they have a shorter duration in action. Examples, we have replinide, nateglinide, and metiglinide. Okay, so this one, they stimulate insulin secretion from beta cells just like sulfonylureas. The mechanism of action is that they work by targeting the same beta cells receptors as sulfonylureas, leading to an increase in insulin secretions. However, their mechanism of action is more rapid and short acting compared to the sulfonylureas. So for longer control and better control, you find that sulfonylureas now will be better than the meclinitides. But the meglitides will be good when we want to reduce when there are spikes, high spikes, okay, in hyperglycemia. Let me say it by looking at the indication. Is that the meglitides are prescribed to lower blood sugar in patients with type 2 diabetes, especially those who was just experiencing post-prandial after meal hyperglycemia. They are typically taken before the meals to help control the rise in blood sugar after eating. So unlike sulfonylureas, the magnetides have a rapid onset of action and shorter duration of effect. They start working within 15 to 30 minutes after ingestion and peak its effectiveness within 1 to 2 hours. This helps them particularly useful in managing post-meal glucose spikes. Okay, so after eating and you really want to reduce the amount of glucose in blood, which oral hypoglycemics are you going to use? The meglitides. Okay, so like sulfonylureas, they can also cause hypoglycemia, especially if the patient skips a meal or eats very little after taking this medication. So apart from hypoglycemia, um, meglitides may cause weight gain similar to other insulin stimulating medication. So meglitides are usually taken with each meal and the dose may vary depending on the individual's blood glucose level and meal patterns. They can be combined with other medications such as metformin to achieve better glycemic control. Patients need to be educated about the risk of hypoglycemia and how to manage it. They also need to be aware of the importance of adhering to the prescribed dosages and meal schedules. There has been limited data on the safety of meglitides during pregnancy and breastfeeding, so their use should be carefully be considered and alternatives should be explored where possible. The fourth one is the DPP4 dipeptidyl peptidase 4 inhibitors. They are also called gliptins. They are a class of antibiotic medication used to treat type 2 diabetes. They work by targeting the enzymes dipeptidyl peptidase, which normally play a role in regulating blood glucose level. Common examples include sitagliptin, saxagliptin, ligagliptin, algogliptin. So the gliptins, the DD4. So this enzymes guy is, so they work by inhibiting that enzyme, okay? And remember, when you are talking about insulin, we say insulin is normally produced in response to presence of food or incretins, okay? Incretins, guys. So incretins, this is how they are being targeted here, okay? So DPP work by inhibiting the action of the DPP4 enzyme. So this enzyme is responsible for breaking down incretin hormones. Okay, so when you inhibit the DPP, it means the incretins are constantly going to be present. And what did they say stimulates the release of insulin? Presence of food or presence of incretins. Incretins. So by inhibiting DPP, this medication increases the levels of the active GLP-1 and GP in the bloodstream. So these hormones promote insulin secretion, presence of incretins, stimulate, promote insulin secretion, inhibit glucagon release, slow down gastric emptying, and reduce hepatic glucose production, leading to a better glucose control. So indication, they are normally prescribed to lower blood glucose in patients with type 2 diabetes, also used as an add-on treatment when lifestyle modification and other oral anti-diabetic medications such as metformin are not sufficient to control the glycemic targets. They have also shown to reduce the levels of the HIC about 0.5 to 1.5 depending on the specific medication and dosage. the risk of hypoglycemia is at a lower risk, but when combined with other medication, the risk is there. We have common side effects of DPP-4, which include headache, upper respiratory tract infections, and gastrointestinal symptoms. Severe allergic reactions are rare but have been reported. Dosing adjustments may be required when patients have moderate to severe renal impairments. In combination, these medications can be combined with other medications such as metformin or insulin to achieve better glycemic control. Patients taking these drugs should be educated about the importance of adherence to their prescribed dosages and signs of hypoglycemia. There is still limited data on the safety of the DPP-4 inhibitors during pregnancy. Next, we have the SGLT inhibitors, the gliflozins. Okay, gliflozins. So, this is a class of oral anti-diabetic medication used to treat type 2 diabetes. They work by targeting the sodium glucose co-transporter 2 in the kidneys. So, this transporter is normally responsible for reabsorbing glucose back into the bloodstream. Remember, glucose is not supposed to be excreted, yeah, through the kidneys. So it's normally reabsorbed back to the body. So what these drugs do, they inhibit that process so that instead of glucose being reabsorbed back into the bloodstream, it is excreted. Okay, so by inhibiting the sodium glucose co-transporter 2. This medication increases the excretion of glucose in urine, leading to lower blood glucose level. So mechanism of action, they block the reabsorption of glucose in the proximal tubules of the kidney, and increases the amount of glucose being excreted in urine, helping to lower the blood glucose level. Indication, these medications are normally prescribed to lower blood glucose level in patients with type 2 diabetes, and they are typically used as monotherapy or in combination with other anti-diabetic medication when lifestyle changes and other oral drugs are not enough to achieve glycemic control. Examples of sodium glucose co-transporter 2 inhibitors include, remember the gliflozin. Yeah, so we have the canagliflozin, dapagliflozin, empagliflozin, and etugliflozin. Remember, the sodium glucose co-transporter 2 inhibitors have shown to reduce HIE levels by 0.5 to 1 depending on the drugs. This medication can lead to excretion of significant amount of glucose in urine, which can result in significant weight loss. There have been relatively low risk of causing hypoglycemia when used as monotherapy. However, when you combine the sodium glucose co-transporter 2 with other medications, they may lower blood glucose and the risk of hypoglycemia will increase. Common side effects of sodium glucose co-transporter 2 inhibitors include urinary tract infections. Remember, we're having more glucose in the urine, so it's attracting more microbes there. Genital yeast infections, especially common in females, increased urination. They may also cause a small increase in the risk of dehydration and blood pressure. Sodium glucose co-transporter 2 inhibitors may require dose adjustment in patients with moderate to severe renal impairment. Certain sodium glucose co-transporter 2 inhibitors have shown to have cardiovascular benefits, including the risk of major adverse events in patients with type 2 diabetes and established cardiovascular disease. So patients taking these sodium glucose co-transporter 2 inhibitors should be educated about the importance of adherence to their prescribed medication and the need to regular monitoring of blood glucose and kidney function and signs of hypoglycemia. Sodium glucose cotransporter 2 inhibitors are generally not recommended during pregnancy and breastfeeding due to limited data on their safety in most population. The next drug are the thiazolidines. Thiazolidines, we call them the glitazones. Okay, they primarily act on the peroxisome proliferator activated receptor gamma. We abbreviate it as PPARY. And this one in cells leading to improved insulin sensitivity and glucose utilization. Mechanism of action is that the thiazolidines work by activating the PPARY, which is a nuclear receptor found in adipose tissue, skeletal muscle, and the liver. So activation of this receptor increases insulin sensitivity in these tissues, resulting into enhanced glucose uptake by the adipose, by the skeletal, and finally by the liver. Additionally, thiazolidines reduce production of glucose by the liver. Indications. They are normally prescribed to lower blood glucose in patients with type 2 diabetes, are generally used as a second or third line therapy when the other medications such as metformin and sulfonylureas like the glimbeclamide are not sufficient to achieve glucose or glycemic control. Examples of thiazolidines include the pioglitazone and the rosiglitazone. They are also able to reduce the HbA1c levels approximately 0.5 to 1.4. The primary function of the thiazolidines is to improve insulin sensitivity in target cells, the skeletal, the adipose, and the liver. Hypoglycemic risk is that these drugs, they do not typically cause it, but when combined with other drugs, the risk increases. Common side effects of thiazolidines include weight gain, fluid retention, edema, increased risk of fractures in some individuals, and they may also cause mild anemia, changes in lipid profiles. That is increased HDL cholesterol and decreased triglycerides. Due to their potential effect on the liver, regular monitoring of the liver function is recommended for patients taking the thiazolidines. Studies also have shown mixed results regarding cardiovascular effects of the thiazolidines. Some evidence suggests an increased risk of heart failure in some patients, while others indicate potential benefits on cardiovascular outcomes. Patients taking thiazolidines should therefore be educated about the importance of adherence to their prescribed medication, the signs of potential side effects, and the need for regular checkups and blood tests. Thiazolidines are generally not recommended during pregnancy and breastfeeding due to the limited data regarding their safety. Next, we have the alpha glucosidase inhibitors. So, where do these work against? This one, they work in the intestines. So let's get to know. So they work by slowing down the digestion and absorption of carbohydrates into in the small intestines. This results into gradual increase in blood glucose level after meals, rather than spontaneous. So this results in gradual after helping this to reduce the postprandial or after meal hyperglycemia. So alpha glucose inhibitors work by inhibiting the action of alpha glucosidase enzymes in the small intestines. These enzymes are responsible for breaking down complex carbohydrates such as starches and diglycerides into simpler sugars, glucose. Okay, remember the simplest form of carbohydrates is glucose. So these alpha glucosidase inhibitors, they block that conversion of complex into simple for absorption. So when that happens, This delay the absorption of glucose, which leads to slow increase in blood glucose level, okay, after meals. They are indicated for type 2 diabetes, of course. They are often used as an adjunct to diet and exercise when lifestyle modifications and other oral anti-diabetic medication are not sufficient to achieve glycemic control. Two examples are common here. We have acarbose and the miglitol. They also have the capability to reduce the HB1IC about 0.5 to 1. These drugs are particularly effective in reducing postprandial hyperglycemia, which is a rise in blood sugar levels after eating. Alpha glucosidase inhibitors have a lower risk of causing hypoglycemia when used as monotherapy because they do not stimulate insulin release. Common side effects of alpha glucosidase inhibitors include the flatulence, bloating, diarrhea, abdominal discomfort. These GIT disorders are primarily due to the undigested carbohydrates reaching the colon. Okay. So alpha glucosidase inhibitors are typically taken with the first bite of each main meal. Alpha glucosidase inhibitors can be used in combination with other drugs to achieve better control. Patients taking alpha glucosidase inhibitors should be educated about the importance of adherence to their prescribed dosages. Alpha glucosidase inhibitors have limited data regarding their safety during pregnancy and breastfeeding. Therefore, their use during this period should be carefully considered, and where alternatives are possible, they must be explored. So guys, in short, we can be able to say that the choice of oral hypoglycemic medication or combination of medication depends on various factors, which includes individuals' health status, kidney function, other medical conditions, and treatment goals. It is essential to follow the doctor's recommendation and to monitor blood glucose levels regularly while taking this medication. Okay? As with any medication, there may be potential side effects and interaction, so it's crucial to discuss this with your physician. Okay, so guys, those are the 8 oral hypoglycemic agents that we know. Okay, starting with the biguanides, sulfonylureas, meglitides. Okay, the DPP4 inhibitors, alpha glucosidase inhibitors, okay, the thiazolidines, okay, and the bile. Okay, so guys, these are some of the 8 classes of oral hypoglycemics. Remember to look at them and revise. So guys, we have a quiz just to check to see if you have understood the topic. You can access my free quiz in the description section. Thank you so much and have a wonderful night.